I was once a proper doctor in the UK. One evening my half day, I just got out of the operating theatre at about 9 o'clock at night, and I was looking at the part of the medical journal which I understood, which was the situations vacant, the jobs. And there was a job in Bermuda for residents, tax-free. They paid the airfare. So I applied and I got the job in Bermuda. From there I went back to the UK, and then I was a ship surgeon. I travelled to Australia, did some general practice in Australia, which was a very interesting challenge. And I was back on my way around the world, and I ended up as medical director of the hospital which I'd been a resident in Bermuda. And while I was there, we joined the Canadian Accreditation program, because there was no other program on accreditation except the American one, the Joint Commission. And I became a surveyor with the program, and I brought a lot of these North American ideas back into the UK in the late 1970s, and found people very resistant to those ideas about external assessment of hospitals, ideas about clinical audit, ideas about credentialing, appraisal, continuing education. They didn't happen in Europe. I rather regret to discover that external assessment is actually part of the title of this presentation, because I prepared it more around academic implications. So perhaps I shall cut this a little short and, if you wish, move more into external assessment, by which I'm referring to a variety of approaches to healthcare, some of which are voluntary, such as accreditation, some of which are not really designed for healthcare, such as ISO certification, and others which are regulatory, sometimes called supervision, or even a form of licensing, all of which are using some kind of organizational standard against which you are assessed by auditors, if it's certification, by surveyors, if it's accreditation, or by inspectors, if it's regulation. And one of the difficulties I have in many countries is trying to understand the relationship between these different approaches. I have the same problem in Indonesia too. But I won't get into external assessment too much at the moment, except maybe to repeat what I just said to the Dean. I had the privilege of sitting in on the feedback from JCI yesterday afternoon at Dr. Sarjito. And I think my understanding of what was said may have been different from other people's, because what I saw was between the lines. They were saying, this hospital has achieved an enormous amount. There are a few little bits you might take a bit further, but essentially you've achieved a lot. But I'm not sure that everybody else understood that. Maybe that's my interpretation. However, now perhaps I should return to my text. So I'll explain where I came from. And I really wanted to start off by looking at the relationship between changing behavior, learning, attitudes and skills, and quality in healthcare. Next one, thank you. I just gave some of this to the students a couple of hours ago, so I hope I don't repeat it too much for those who are here now. These are the views that we had about what is quality when I returned from North America to Europe. And this guy, he was the secretary of the King's Fund, which is a well-respected organisation in London. It's quite independent. And he was making the point that there are many dimensions of quality, and sometimes they conflict. The first two are perhaps about public health, about social value, about fairness, so that people of all classes, all bits of geography, all levels of finance or income actually have equity in the system. And this becomes important when you start having universal coverage, as will be beginning here apparently in January next year. I'll also raise some issues about accessibility to healthcare in terms of geography. And I'll show you some examples of that, because it develops a tension between having everybody accessible to every service you could possibly want very near to you, or whether we have to rationalize and say, no, you'll have to go to a specialist center. Effectiveness, the idea of testing, technology assessment, to validate the results of certain interventions under the right conditions. Then we've got acceptability, which is a completely different angle. This is the public's viewpoint, the patient perception, which again may be in conflict with the evidence base. And one thing I discovered in America a long time ago, at least when I was first a resident, nearly all our residents were trained in Europe, and nearly all our patients were trained in America. And we had a real conflict about, if they demand an X-ray, do you do an X-ray? Whose right is it to decide? And we had big arguments about that. Then there's efficiency, particularly when you're talking about costing healthcare. You cannot ignore the fact that it's not just a matter of resources, it's a matter of how well you apply the resources. And finally, may I say appropriateness. And that is using the right technology on the right patient. Effectiveness is fine. For example, we had big problems in the UK with the introduction of what I call wiggly tubes, endoscopy, and particularly endoscopic surgery, that in the hands of somebody who's skilled and knows how to use it, it's a wonderful instrument. But we were perhaps lucky in the National Health Service, when I was a manager in there, we couldn't afford the technology. So it was the private hospitals who bought the technology. And they didn't have the courage to say to their surgeons, you're not using it until you've trained. So in effect, the surgeons trained on private patients in private hospitals. And I know this because the insurance companies told me what happened afterwards. So introducing new technology is quite a key issue. So using it the right way, the right patients. The one dimension which was not really mentioned in the 1980s was safety, which has now become one of the big issues. Next, please. I'll come to that after. This slide I actually stole from the National Institute for Clinical Excellence in London. It was a preface to a presentation they were giving on the argument for clinical practice guidelines. But I've heard many of these comments from other places. A real problem we have is to do with population demography. That the science of medicine, which applied in the good old days when patients only had one disease at a time, is changing. Not only is the population much older, certainly it is in much of Europe, but also many of them have multiple morbidities. So the clinical guideline that used to make sense when you only have one disease at a time gets very complicated. And frankly, we don't have enough research to know exactly what happens when you have 3 chronic conditions at the same time. We've also got enormous increasing demand. The public are well informed, they read about latest technology, and they want it now. But it costs a lot of money at the very time when most economies are going downwards. So we'll always have this tension. And the problem of what essentially has to be rationing. And you can ration any way you like. But sooner or later, you have to say, we're not going to invest any more. And this is difficult when you're trying to balance individuals' interests versus population interests. Because for the individual patient to extend their life by a month or 2 with an expensive drug may seem a good idea, but for the population as a whole, that is not a good investment. So who makes those decisions? Is it the economist, the clinician, healthcare planners, health insurance? So patterns of disease. I was intrigued to see in one of the papers in Jakarta last week a report from a group of Dutch cardiologists who were pointing out that the response of an Indonesian patient to heparin and to antihypertensives can be quite different from a Caucasian population. Now, this worries me because we have to be very careful about adopting clinical practice guidelines from another population if the epidemiology is different. And it also will affect some of the things I'm about to show you about management of acute myocardial infarction, for example. So epidemiology is another issue. The fact that knowledge is growing so fast, we cannot expect clinicians who are pretty busy treating patients also to be able to consume and understand all new ideas, which is a very good reason for what I was describing to students just now as restricting clinical freedom. We have to start specifying what is good practice and expect people to work within some limits. It's also a question of explaining why decisions are made. And a sort of difficult decision I referred to earlier about centralizing certain services. For example, certain services like major trauma, cardiac, aortic aneurysms, leaking. The evidence is you need to centralize them to get much better results. So you have to argue with the local population as to why we're taking the service away from your population and putting it somewhere else. And this is a very difficult issue. Unfortunately, when it comes down to it, the research-based evidence frequently says this, but the politicians cannot do anything but that, for different reasons. So there are a lot of tensions here. It's time I got on with this business. Can I have next, please? So let's start off with this problem of safety. Originally it was called medical injury, and I would suggest you use that term with caution, because medical injury suggests somebody's done something. Medical error suggests there's a blame involved. So I'd rather use the word adverse event. But going back to 1991, what's called the Harvard Medical Practice Study looked at a number of patients, several thousand, discharged from hospitals in the Boston area. And they were surprised. Actually, it says New York there, but it was actually Boston. They found that about 4% of patients were damaged in some way, minor or major. And they thought that was terrible. But it started other people asking the same question. And successively, Australians, French, Dutch, New Zealanders, all started looking at this. And we've now come to the conclusion, after everyone's done it, that it's probably, across the world, about 1 patient in 10 is damaged on admission to hospital. Now, I don't know whether anyone's done the study here, but I did say to the students, if you want a good thesis or a good subject for a thesis, maybe you'd like to do a study here. Could be valuable. But damage is obviously, it affects patients. It also affects costs. There was a particular example from Tunisia, which I came across, which found that in the undamaged discharged patients, the length of stay was 5 days. But the very same case mix who had a complication, it was 12 days. So this is occupying hospital resources, it's occupying costs, it's an unnecessary expenditure. Never mind the patient. They might not like it either. So, the next, please. So the cost comes into this. And I'm currently working with the Health Insurance Fund in Estonia, which is a very small population, right on the edge of Russia, on the edge of Europe, and it's cold there. And we were talking about things that influence costs. And in particular, one thing we came upon, and I'll give you some examples locally, was that certain fairly new technologies are expensive but are extremely cost effective if they're given at the right time. But if you give these expensive interventions when it's too late to give you the diagnostic lead you need, or actually to reverse or prevent the destructive process of hemorrhagic or ischemic stroke, for example, it is not good investment. There's also this issue about centralizing services. To what extent should you supply every hospital with every technology and have a fairly low throughput, which means the staff will never be very skilled at it? Or do you put them into a centralized unit where you have whole teams who are trained in doing this all the time, and those people get very good results and they're much cheaper? So how do you get this trade-off? It's particularly true of vascular surgery, incidentally, pediatric surgery. So how do you control this? There's also the problem, which really comes down to numbers, information strategy. Are we talking the same language when we talk about length of stay or adjusting for case mix? And health insurers basically are money people, and they rely quite heavily on epidemiologists and clinicians to help them understand what these different things mean. And then there's also issues about unnecessary things in the sense they should not have happened in the first place, which is partly a public health issue, but certainly chronic diseases in diabetes. You're probably familiar with the next few pictures. If we're going to try to grapple with these problems, we need to start measuring them. We need to get a hold on them and analysing them. And you're probably all familiar with, it's attributed to Donabedian. He was a charming Armenian who came up with this. It's actually a variation on Henry Ford, who made motor cars. Now, Henry Ford making motor cars, it was relatively simple. You could measure what goes in. You knew your manpower. You knew how many tons of steel you had. You knew how much money you were spending. And you knew your output. You knew how many you produced. You knew how much money you sold them for, so you can work out the balance between the inputs and the outputs. When you translate this to healthcare, it's a bit more difficult. You'd say, well, it's okay for surgeons and obstetricians because you've got an immediate output which you can measure. And you measure it now. Whereas in some things, it's actually one thing is difficult in obstetrics, is damage done during delivery may be not actually detectable for many, many, many years. Which is why, in terms of retention of medical records, there's a thing called the statute of limitations in most countries, which means you have to keep your medical record for more than 6 years, because that's the period in which you have to make a claim to be successful if you say you were injured at birth. Not at birth, it's 18 years in the UK, because that's the point at which you could reasonably say this child was or was not damaged at birth. So I don't want to get too much detail, but I'm saying outcome is easier to measure in some specialties than others. In chronic disease, in primary care, maybe we ought to be looking instead at process. What is the procedure you followed? So this is one use of evidence-based medicine. Next, please. All of these improvement ideas are not just about quality. You could say the same thing about management by objectives. What is it you want to do? Where are you now? What do you have to change? Or even, I would argue, a neurofeedback loop. Where do you want your finger to go? Where is it now? Proprioception and motor systems making it happen. If we apply this to quality and improvement, we've got clinical practice guidelines. We've got accreditation standards. We've got patients' rights. And we've got measurement systems. We've got clinical audit, indicators. We've got surveys of patients, surveys of hospitals. So we've got measurement processes. And there's a tremendous amount of effort put into those two. very little effort goes into making anything happen. And that's what I'd like to move on to. Next, please. I'm sorry, this is complicating that last picture. And had I more time, I would take it through about 35 slides, moving bit by bit. But let's start. I'll have to point. The top left-hand corner. We start with, thank you, biomedical research, health technology assessment. These are the basis for developing clinical guidelines, pathways, protocols, call it what you like. So that gives us a lead into clinical standards. I would like to think that the basis of accreditation standards is in health service research. That was hard evidence. In reality, not many of them are, but we do know that a lot of the evidence we have behind patient safety is actually fairly good evidence for systems that you must follow, or at least certain things you must not do, like putting concentrated potassium chloride on the shelf in the general medication store on a ward. Things like that we've learned empirically. So it is actually a form of research, but we're learning from errors. So that gives us our standards, begins to. We've got measurement processes, as I mentioned, all kinds of different ways of doing it. Peer review is another one, which I hadn't mentioned, of having teams of professionals just looking at each other as a peer review process. Not a top-down, but a sort of bottom-up, self-regulation. We talked quite a bit with the students about the role of self-regulation of professions. And I said that there's a culture slowly moves through where you come away from the expecting to be told what to do to when, as a profession, doctors actually lead themselves within the scientific guidelines. But the important bit is really here. How do you actually make improvement happen? And again, I'll give some examples over delay in initiating treatment. It isn't just a clinical issue. It involves lots of other people. One of the people might be the patients, the consumers. And media, what's in the press, what's the view that goes out to the public through the public media? And I think I learned as a hospital manager not just to ignore the press, because if you ignore them, they will never be very helpful. I actually had an argument with the chairman of my board. I said to him one day, do you think it'd be a good idea if I hired some public relations people? No, waste of money, he said. I went ahead anyway and hired some public relations people. And about a year later, he said, Charles, you're getting very good publicity in the hospital recently. Did you do what I told you to do? I said, no. He said, well, I'm glad. Because it may sound like you're managing knowledge, but I think it is important that the image the public get of what you're doing. So I would often argue to people, if you're trying to get the public on your side, you've got to put your message across very strongly. So that's one approach. One of the most powerful influences on changing the way things are is to change the way people get paid. If you stop paying somebody for doing something, they'll probably stop doing it. Similarly, if you start paying them for something else, they will probably do it. And this applies to individuals, it applies to organizations. So we'll keep coming back to the payment issue. One of the key areas which is a bit slow to respond, I'm afraid, is often the teaching, the academics. As I was just saying to the students, it took 10 years after medical audit was mandatory for doctors in the UK health service. It took 10 years for the Royal Colleges, the professional associations, to say, we've all got to do it. It took another 10 years for the postgraduate medical education curriculum to catch up with the 20 years earlier. And it took another 10 years, I just said, for the General Medical Council this year make involvement in peer review medical audit mandatory. It's a condition of your relicensing. If you're not involved in it and you can't show you are, you lose your license. So this process moves along. So training is certainly one of the issues. And in management, are our managers actually trained to make the sorts of changes, to re-engineer the system to fit around the patient and the clinical evidence? And again, I'll come back to examples over reconfiguring services to reduce delay in interventions. But one of the most important things is, what's the attitude of your colleagues? Again, I just showed a slide that in the late 1970s, the British Medical Association, far from saying we take responsibility for self-regulation, said it's nothing to do with anybody. We don't need to be interfered with. We are qualified doctors and we don't need any further supervision. Things changed, but I do think it's important. There's also within the Ministry of Health, all ministries of health have some responsibility for overall planning of services, helping to allocate the right resources in the right places, helping to introduce concepts. When all of these arrows are pushing in the same direction, things begin to happen. But if you just try any one arrow on its own, it has limited effect. If you must have only one, go for payment. Because for all the things we'd like to say about ethics and well-being, money does count. Next, please. So I would say there's a certain amount of science in this, about research, about technology, about measurement systems, and that does raise a lot of questions about having an information strategy across the country. But this is the real problem. How do you actually change things? Next, please. Next. So that's a sort of very general look around the world. And now to come down more specifically to some projects that are currently going on here. I was originally asked to come here to help with the HAPPY. I probably have to ask again. It's a hospital accreditation program, implementation, evaluation. Anyway, it's something to do with evaluation of accreditation. I must admit I'm a little cynical about that, because trying to compare three groups of three hospitals, the ones that are accredited by JCI or working towards it, and the ones which are accredited by CARS or working towards it, and the ones which are neither of those, well, a sample of three is not a very powerful statistical argument. So I prefer just to put all nine together and to say, what does this tell us about possibly hospitals in Indonesia? Except these are all A-class hospitals, so they're not really representative. I'll also talk to you a little bit about CARS accreditation. Although off the cuff, I haven't got all the slides. While I'm here helping design this project, this study, I was asked by World Health Organization, could I have a look at CARS? I talked to them, because I'd had some contact with them years ago. I did an international survey of all accreditation programs in the world. And when I sent the request to Indonesia, I got no answer several times. So I had thought they'd gone. But no, they didn't. They popped up in Hong Kong and told me, we're still here. So we've been talking to them. From these two, one which was meant to be about evaluating external assessment, and another one which is about one of the programs itself, we begin to learn quite a lot about some bigger issues. And one of these is, what's the limit of function of accreditation, an accreditation organization? Can that really be the body that takes on technology assessment, clinical practice guidelines, consumer complaints management, clinical skills, quality management training. And I was saying, no, look, that's not reasonable. No country can do that. And I did say to the previous Director General, Dr. Supriantoro, you can't ask cars to be responsible for everything. We need to look more widely at who else is involved in this. So I managed to persuade, who did I persuade? Well, I actually persuaded USAID. Comes back to money again. If you can get the person with the money to go the direction you want, you're okay. Then they got WHO to agree to let me do it through them, and they then recruited 4 people from UGM to actually do some of the mapping. What we're trying to do is to actually identify what's the policy behind quality improvement in Indonesia, either in terms of governmental policy or legislation or professional statements about ethics and so forth. Who are the people involved in it? What about the academics? What about the managers? What about parts of the Ministry of Health? What about cars? What about various bodies? What sort of methods we're using? Who's got what projects running in which provinces? And then with a view really to beginning to analyse what's the relationship between all these? What does it tell us about the need for more coherence? So I might come to that in more detail later on, because it ends on. So let me come to some of the findings. I won't go into detail, partly because I haven't got them, and I'll tell you now, I don't know the identity of each of the hospitals, but I can tell you Dr. Sarjito is one of these 9 hospitals, but I don't know which one. It's very convenient I don't know, because I can't answer any questions about it. So. But just as a general outline, there were various things we did. I mean, we went to ask patients, we had interviews with staff, but the bits which I designed are the ones which I most like. One is an organisational audit of the hospitals, actually looking at systems, observing things you see. The other bit was a clinical audit, taking 30 cases across 4 tracer conditions in 9 hospitals, so about 270 patients in each of the clinical audits. The 4 conditions were hip fracture, acute myocardial infarction, normal delivery, and pediatric pneumonia. I think the hip fracture was a mistake, which we should have spotted. It's about epidemiology. Hip fractures don't really happen much in Indonesia. They're very high common things in Northern Hemisphere, possibly because they're not built so well as you are. I mean, they're longer limbed and they're sort of overbalanced easily. And maybe it's just because it's cold and icy. Because a lot of these things are from people sliding on ice. And that does terrible things to bones, particularly for elderly people. So anyway, those are the 4 conditions. The most interesting, perhaps, is acute myocardial infarction, for a whole number of reasons. Interestingly, when I've been researching evidence from other studies, it seems that acute myocardial infarction, which I'll call AMI from now on, is more studied than most other conditions. I think possibly because there's a big difference between good performance and bad performance. There's a lot of scientific evidence behind what is good performance. There are massive cost implications, and it saves lives. So it also is one of the conditions which is most closely related between process and outcome. And also, we've been doing a study in Europe at the moment called the Duke study. We're just writing, in fact, it went to press last Friday. I've been trying to correlate the impact of accreditation on clinical outcome. And the only condition in which we see a very strong correlation is acute myocardial infarction. I don't know why. But to come to the organizational audit first, we had about 10 domains, if you can call it that, of issues we're looking at. And you may say, well, this is quite close to, if any of you read avidly the Joint Commission International Standards, you'll see the same sort of headings there. And incidentally, en passant, I would say that JCI standards are pretty well the same as everybody else's standards all over the world. I was on the working party that designed the first version, and we spent a lot of time mapping between the Canadian, the Australian, the British, the German, actually not the German. So the sorts of headings, issues which appear in standards are the same all over the world. What differs is the level at which you measure them. And one problem I have with JCI standards is that because they're so totally global, they're not particularly sensitive to local issues or local policy. And in Europe, I'm on their advisory council in Europe, but I still keep telling them they're going the wrong direction. They don't pay any attention. I pointed out that the European Union has a lot of legislation, regulation, directives which are very specific, and JCI standards don't mention them. So that's one of the reservations I have about having organizational standards which are totally universal. However, having said all that, the criteria we're using here mostly came out of a study we did in Europe, I admit, of European regulations from the World Health Organization, from the Council of Europe, and the European Council, which confusingly are not the same. A lot of good advice, legislation too, legislation about mobility of workforce, about recognition of qualifications across borders, about freedom of movement of patients, the right of a European citizen to go to a next door country or another country within the Union to have their hip replacement and have it paid for by their own government. So you can see that in terms of commerce and cross-border care, this is quite a big issue, which JCI standards don't deal with. So we've invented our own, at least I have. And that is largely the basis for these criteria. But as I say, they look very similar to your JCI ones. Just in short, we've only got 9 hospitals, so it is not very significant. But I'm sorry about the labels being upside down. I'm not very good at Excel. As you'll see, the ranges from about 95% compliance with the criteria of hospital governance in the best hospital and less than 50 in the worst. As I say, the worst may be different hospitals here, I don't know. Human tissue and transfusion was actually rather easy because there were only, I think, 3 criteria. Within the European Union, this is quite a big issue about the transfer of organ donations, etc., across borders. That's why there's a lot of emphasis put on it in Europe. Blood transfusion, organ donation, cell transplants, and very complicated technologies. Mostly they're not used here, so it was not so much a problem. But in general, I'd just say that in almost all spheres, there was a surprising range. And I would like to think that accredited hospitals would be somewhere within this area. It obviously depends where you set your pass mark, which is maneuverable. So that's the overall picture. Next, please. I'll just give you some of the qualitative answers that came out and explain maybe why they were there. This question about professional qualifications, I think the JCI called it primary source verification, or something like that. If you're in a community where you have a lot of immigrant doctors, as we do now in Europe, because of the freedom of staff to move between countries, a doctor trained in Poland has a right to work in the UK, subject to being registered. If you employ a doctor from Poland, somebody has to verify that they are a doctor and they are from Poland, which is actually quite difficult because there's no central registry. I mean, people registered in your own country, oh yes, we know exactly where he trained, we know what specialty he is, we know where he graduated from, what training he had. But you try and ask him that for somebody else, somebody else's country. So, but even in the States, in North America, this was a common problem because of the shifting of clinicians across between, say, state boundaries. It was quite easy to find that a locum doctor would offer himself to work in your hospital. And it's only much later you find he was struck off by the next door state and he simply moved across a border. So all hospitals, I think, whether you're a single nation state or whether you're not, need to have some system. Anyway, the answer is at least 4 out of 5 do. But you may say, is that enough? Shouldn't it be 100? Another one about training in cardiopulmonary resuscitation and continuing training. I'm quite surprised it's that high, actually, nearly 90%, because I think in reality in Europe it's much lower than that. But I think maybe it's a matter of how well this was verified. I was impressed that even to go as high as 72%, actually documentation of continuing medical education. I think that's impressive, but I'd love to see a little bit more detail. But I just want to keep going back to the point that the relationship between improving quality and service and education. Next, please. Here's a much more specific one. Now we're moving into the clinical audit. We put all these together as a bundle. How many of these hospitals actually had all of these? Percutaneous intervention and or fibrinolytic treatment, thrombolysins, coronary angiography, and ambulance telemetry. The ambulance telemetry is perhaps moving to the pre-hospital phase of management. Rather than putting a patient in an ambulance, driving as fast as you can to the nearest hospital, it's worth thinking about, could we do a little bit of telemetry, work out whether in fact this patient does have a myocardial infarction, and take them direct to a unit that has the appropriate technology. Some countries, exactly, I would say Poland were quite upset when we used similar criteria in the Duke project, that we'd even asking them about streptokinase. They said, we don't do that. No, we send them all to specialist units because all the ambulances are equipped with telemetry and there's somebody helps triage the patient before they've even got to a hospital. So things vary. But the answer here was, yes, some hospitals have all of these and some of them have very little of it. So it's, to me, starts thinking, how do you organize this in a country? When you've got the public sector, you've got the private sector, should somebody be trying to reorganize things so that we actually get the right patients to the right hospitals? Or should we be equipping all hospitals to the same level? This is a rather different issue, was asking about, do you know whether your resuscitation equipment works? It may sound like a very silly question, but it's astonishing how often people say, oh, yeah, it's fine. And when you actually go and look at it, the laryngoscope doesn't work, the light bulb doesn't work. Why? Because the battery is dead. Defibrillator's dead, no one's charged it. No one can find the drugs. The potassium chloride's gone out of date. No, not the potassium, it's sodium. Sodium bicarbonate is the one that goes out of date. No one's checked it for ages. There'll be no engineer calibrate whether the 150 joules marked on the defibrillator is actually 150 joules. There's no common training so that some people do 30 compressions for 2 ventilations, some people do 15 to 2. You've really got to have everybody doing the same thing. So looking at cardiac arrest crash cards are actually very informative. If you only have 15 minutes to assess a hospital, go to the nearest crash card, and they'll probably tell you about an awful lot. Anyway, so we asked in this whether you actually do have a checklist specifically saying, yes, this item was checked by this person at this time, maybe 3 times a day. So we know. And I suspect that's what JCI have been looking at. So here, well, nobody seemed to comply with that. And at worst, about 1/3. Next, please. This gets, I think, more interesting. There are 2 issues appear here. Of the patients who arrived with a myocardial infarction, the majority had thrombolysis, but a minority had percutaneous intervention. I guess that's because the hospital didn't have the facility, because you need a cath lab, and not everyone has them. They're very expensive. So again, we come back to the question, should we be equipping everybody with cath labs, or should we be accepting that we use thrombolysin instead? Who makes those decisions? Is it public health? Is it director of finance or the health insurance people? So there's the issue about resource allocation, equity and access to care, which going right back to the beginning, one of the big issues in quality, access to care. What I found interesting, and I felt I had to include in this here today, is that overall, 1/4 of all patients coming with a myocardial infarction were treated with antibiotics. I wonder who taught them that. This is average. In some hospitals, it never happens. In some hospitals, it always happens. So whose business is it to question that? What's the mechanism in Indonesia by which somebody would say, that's not right? And certainly I would say to the health insurance, universal coverage, whatever you call it, you shouldn't be, if you're paying for a DRG full of acute myocardial infarction, don't pay for that. So I'd be very interested to know if you have any suggestions as to how to manage that. Next, please. When the patient comes to be discharged, and again I have to repeat that these particular audit criteria came straight out of the Duke project in Europe, which is based on a number of randomized controlled trials and evidence. But that evidence comes from mostly Caucasian populations. And I think we have to be careful about translating that here. But essentially, the common thinking now, certainly in the UK, in France, North America, Canada, is that unless contraindicated, every acute myocardial infarction patient should be discharged on a bundle of 4 drugs: beta blocker, ACE inhibitor, statin, and aspirin or antiplatelet. So how many are? Well, it seems on the aspirin side that at least one hospital is 100%, but as you see in the others it gets less, and in some it's extremely low. Now, is this a question of affordability? Is it because the patients can't pay for it, so they're not given it? Is it that the doctors didn't think of prescribing it? Is it that it wasn't available? So what is it behind all this? And for that matter, what price should health insurers put on an AMI package of care? Because they've got to cost out their reimbursement rates, tariffs. So should they cost it out on the assumption that everybody gets these 4 drugs, or should they not? So a little difficult. Next, please. One of the other things that we asked, and again we asked it in the European study, is to what extent do clinicians actually systematically review their clinical practice? as I just said, it is now in the UK, it is actually a condition of your registration as a doctor that you are involved in it. A bit before that, the academics said we're going to be teaching it. A bit before that, the professional association said we think we should be doing it. And it was before that that Margaret Thatcher said you're going to do it. So it does take time. So what's happening now? Now I'm quite pleased, I think, that the students here are learning about peer review clinical audit. Although I must admit they weren't very forthcoming when I asked them to confirm this a couple of hours ago. But the general feeling is that they're on the right path. So what's happening in the field? Well, obviously these are not very good, not reliable, but the doctors involved in the medical cases, the acute myocardial infarction, maternal and child health, surgical, hip, and pediatric pneumonias. The scores are not very exciting, but the general message you get is probably about half of the departments do some sort of clinical review sometimes, and some of them do none. And I think if we're going to get professionals and clinicians to start taking responsibility for their performance, then they have to get involved in the process. Next, please. So, coming out of the study are a number of issues about planning, about this issue about locating MRI scanners. Somebody has to take a role in this. Now, is this the Ministry of Health? How do you rationalize high technology? It becomes particularly difficult with very specialized services. Pediatric cancers is certainly one major problem. And in Europe, we're talking now not just about primary, secondary, tertiary centers, but for things like childhood cancers, quaternary centres, which may not be in any one country. You may have to send them to another country to get to people who really know about this condition, have really got the skills and the equipment to deal with it. So somebody has to sort that out. We've got the problem about resource allocation. Again, partly it's to do with money, but it's a matter of putting the two together. It's a matter of not wasting money on streptokinase given 4 days after the myocardial infarction. It's a matter of making your money count. We've got issues about management systems. If it takes more than an hour between arriving at the hospital and getting your streptokinase, the cost-benefit drops dramatically. After a couple of days, it is totally wasted financially. So there are good reasons to be looking at our systems of delivery to re-engineer it. And I'm just saying to the students, you cannot leave that entirely to doctors. You've got to get managers involved, you've got to get planners, health insurers too. So coming back to my rather complicated diagram of arrows and pressures for change, if everybody is saying we've got to change the way we manage chest pain, and the health insurers recognise it and they reward doing the better things instead of paying for the bad things, and you've got the professions acknowledging the evidence behind this, and you've got clinicians at local level regularly monitoring how are we doing, and possibly making those results available to the public, things will change. So it's very much a matter of management and not just clinicians. And also, telling you management, I think it says something about the undergraduate curriculum. As a junior doctor, I often felt completely, at sea, because I'd never learnt administration. I had no idea what an organisational chart looked like, or job description. No, I'm a doctor, I don't do those things. It so happened I found myself as medical director of a medium-sized hospital, and I had to learn very quickly. To an extent, I think we've got to get doctors more involved in management without killing their clinical abilities and skills. We had a lot of debate in the UK with the invention of general managers. Prior to that, we had administrators basically who ran hospitals. The idea of having a general manager who ran everything was quite revolutionary. I was one of the first doctors to do that. I think 12 of us in the whole country. And I was general manager of 3-4 hospitals. And it was really quite intriguing. One of my next-door neighbours, who was general manager of the Oxford hospitals, he was a radiotherapist. And we had a lot of discussions about how long can you be a full-time manager before you lose your clinical credentials? How many days a week can you spend on management instead of being a doctor? And we came to a general conclusion, the same issue occurred to a lot of people, that probably you could be half a doctor for about 3 years, but then you've got to go back to being a proper doctor. And the radiotherapist did eventually go back to radiotherapy. Mr. Chris Payne, if you know him. So management and medicine, I think we've got to look at balance between these things. There's also the question about who determines what's good clinical practice. You need technology assessment, which is basically looking at research. You need research on the right people, including Indonesians. You need to have a national mechanism for importing these ideas and also vetting them. Is this a good guideline for us, for our people? And the sort of vetting would be, firstly, is the epidemiology actually consistent with ours? Second, can we afford this? It's all very well saying, do an instant MRI scan, but that doesn't make sense in a lot of places, financially. Does it fit our culture, our beliefs? And again, you have to see variations in this, particularly in antenatal screening. An issue that came up yesterday is patients' access to their own records. There are different attitudes around the world, and I don't think we should have a universal imposition on anybody. And certainly I have found in Saudi Arabia the question about who consents to a woman having a tubal ligation. It's not the same as in the States, I can tell you. So the culture, legislation, epidemiology, economics, all should influence the way clinical guidelines are adopted. But somebody needs to organise it. And I'm not quite clear at the moment who does it in Indonesia. And then we come to education training. To what extent are we in tune with that agenda? Next, please. I've got what order I'm in. But I presented some of this to a group of people in Jakarta last March. The people were a few people from University of Indonesia, a few WHO, the CARS people. And I rather regretted there weren't more people there, because I think some of the questions arising from this very first stage of the HAPPY project actually do raise some big questions. So I'm really glad to inflict it on you as well. I'd like to know what you say. So I won't say who these people were, because I don't know who they were. But I got a lot of comments there. Lack of supervision of trainees in academic hospitals. Weak undergraduate training in communication, informed consent. And then some complaint about not being quite clear what is a specialist by definition. I got a funny feeling that this was saying, well, it's nothing to do with us. It's those teachers that don't do it right. So I'm very interested to sort of feed this back to you, and perhaps you could like to comment. Next, please. This slide, actually, I presented to the dean of the medical school in Tartu in Estonia, because I thought I knew what the answers were. I'm surprised how many medical schools are still not teaching students about issues that affect people now and tomorrow. A lot of them are still using the old curriculum, the one that I brought up on, As I said earlier, I got to medical school on Latin and Greek, which was quite useful in certain subjects, but not nearly as useful as chemistry and physics. But what is it in the curriculum? When I was a junior, at least when I was a student, I think we spent far too much time on anatomy, detail of muscles and things which I'll never meet again in my life, and not nearly enough about personal communication, understanding people's motivation, behavior, and so forth. So what are we teaching students? If you want a guide, there was an interesting chapter. There were two publications by the Institute of Medicine in the States. One was called To Err is Human, To Make Mistakes is Human. Followed up shortly by one called Crossing the Quality Chasm. These are available at www or edu, whatever it is, Institute of Medicine anyway. It's free. I think it's chapter 6 or 7 is called Preparing the Workforce. And it talks about what has changed in society that means we ought to be changing the way we teach students. And there's a whole list of things, quite intriguing. So what are we teaching now? One of the points that we found very useful in the United Kingdom when I was trying to console the professional associations and the Royal Colleges, they were feeling a bit battered by Margaret Thatcher. She'd already defeated the trade unions, she'd reorganised the church, the lawyers, and the doctors were clearly next ones in line. With the healthcare reforms of 1989, which split the purchasers and providers in the health service, which caused quite a challenge to us, another of the sections was all doctors will be involved in medical audit, not a choice. So they were quite upset about it, but I managed to persuade them, because I'd just come from North America where this was normal, that if you treat it carefully and you lead it instead of being pushed, you can influence this and you can turn it into a really educational exercise that you learn from your colleagues by sitting down with them, analysing what you do, using evidence-based guidelines. You will learn from your colleagues. So we managed to sell it as continuing education, which is interesting because then the postgraduate deans all came to me saying, we want the budget. If it's educational, we have the budget. I said, sorry. And I'm interested that here you differentiate between undergraduate, postgraduate, which comes under Ministry of Education. But I'm told that in-service training comes under Ministry of Health. I don't know whether I'm right, but this was the difference that I was trying to make in the UK, saying, no, I'm not going to let this budget go to education because it's in-service training. But it does raise a good question. What is the responsibility of hospital directors for the continuing improvement, knowledge, skills of their staff? So, next please. This is what the medical Royal Colleges eventually said in the UK. It was directly in response to the challenge from Margaret Thatcher, said you will. And we had to persuade the professions that they're going to do it happily. If you're going to have to do it anyway, you might as well be in charge of it, lead it. But it took a lot of persuading. The British Medical Association was strongly against it. They said it's an infringement of their liberty, their rights. Slowly they changed their mind. So we had driven this, originally medical audit, doctors only. We mixed it up with other professions and called it clinical audit. And when we added the nurses and the clinicians and the therapists and even managers, we began to realize that's when we started improving the whole service. That's when we started getting the door-to-needle time really reduced, when everybody's working together and we know why we're doing it. So I think the challenge in Indonesia is, for example, how do you sort out this problem about access to MRI scanning? Next, please. as I said, it took a little bit of time, but eventually, nearly another 10 years on, the body responsible for higher medical training, which is the specialist training across the country, okay, you've got to be an oncologist, you've got to be a dermatologist, you've got to be a psychiatrist, but all of you also has to have a number of other skills, knowledges. Clinical governance is a term which is now used in the UK, Australia are as well. America hasn't followed us yet. They don't like following Europe. The idea of clinicians being involved and responsible for their own clinical practice and for helping organize it and its interface with others. Risk management, the whole business of patient safety. But I'd like to say, when we talk of patient safety, remember staff safety as well. And a lot of emphasis, and there was no mention of it yesterday that I could see, or very little about the environmental safety. Loss of electrical supply is very damaging. It happens in big hospitals, including one in Lyon, France. On a Friday afternoon, the entire power supply is shut down. The standby generators, for some reason, did not work. And they didn't restore the power supply until Tuesday, by which time a lot of patients had died. Now, that's in a country that has a phenomenally good power supply, power system. But if you think you're in India, things will be very different. So a lot of issues about risk management are not to do just patient safety. We've got the issue about clinical evidence, scientific evidence, and students need to learn it, specialists need to understand how to interpret randomized trials. If you want to go to the source evidence, you have to understand the language they're talking. You've got to get them to understand how to measure themselves and the use of clinical guidelines. So, as I say, it took until 2003 for that to happen. And I don't think I've got it on the slides, but it's just this year that it's a condition of my certification of my continuing registration with Medical Council in the UK that I can prove I do all these things. I can no longer prove that because I no longer do it. So I've now been crossed off the clinical list. So as of this year, we've separated the medical register in the UK into actively practicing revalidated clinicians and the rest. Next, please. So I'll stop here with this final message, but I'll be very happy if you want to go into more about external assessment and the role of accreditation. I'll be happy to pick it up. But the message here is, don't be too won over by science. Yes, I think it is the role of universities and teachers to do the research, technology assessment, the scientific bits, because this is the stuff that people publish papers on. It's exciting, it's challenging, it's scientific. But what really matters is these things below the waterline, the things that are less obvious. How do you actually make this work? So it's about leadership. It's about people paying you and pushing you to do the things you really need to do. It's about getting systems organized. It's about working with colleagues, not just doctor colleagues, but other colleagues. Learning from feedback, training, evaluation. So I'll stop at that point and invite comment or discussion. The Dean.
Thank you very much. Very interesting lecture for us. I would like to ask you about the condition in Indonesia, because we know that all the protocols usually comes from the European or American, but we don't have any Asian protocol sometimes. So what do you think about this accreditation for this country? What is your opinion? What can we use? Because I saw in your lecture that there are some local condition not be evaluated, not being evaluated. Yeah, that's my question. Thank you.
You're referring to the evidence base behind interventions like thrombolysin streptokinase?
I mean, for like the accreditation. Yeah, usually we use all the protocols, or sometimes for the patient management usually become from the European or the North American, but we don't have any what we call the local from the Asian countries. Maybe we can use it to be evaluated. So what is your opinion about this?
Okay, now I can refine the question a bit better. I think the difficulty is that that's where the research has been done. It was only, I happened to see it in the paper the other day with these Dutch people saying, oh, well, we've actually worked here. From our own personal experience, we can see that the reaction to heparin is different. They also pointed out, for example, that the prevalence of diabetes in cardiac surgical patients is 30% in Indonesian populations and only 15% in European ones. So it strikes me this needs to have an evidence base behind it. And I think before you say, oh yes, we'll just adopt Caucasian-based epidemiology into our treatment regimes, I think somebody needs to validate that here. Now, my question is not about individual hospitals, but it's about, at national level, somebody needs to be seen as the responsible authority. Now, in the UK, we have NICE, National Institute for Clinical Excellence. Rather stupidly, just slightly north, we have in Scotland SIGN. Slightly south, in France, we have HAS, Autorité de Santé, all doing much the same things, but they do work together. AHRQ in the States, but all of them are working on Caucasian populations. So I think one of the things I'd like to see come out in our big national plan would be research into a number of things, evaluation of systems, not just of things like cars, but evaluation of the licensing processes, but also evaluation of clinical practice. And here again, in a way, I come to the question about international standards from JCI. They were designed for a totally international setting, and they weren't designed around what's particular about Indonesia. So I'd like to think all of these are negotiable, but one of the leading principles is base it on local evidence. And that may not be the same as international. What I don't know, and if I were taking my public health viewpoint, I don't know which are the sensitive issues. Do we have to repeat every randomized controlled trial in the entire world for every condition? Or could we begin to say, it looks like the cardiovascular system that we need to look at? So we could understand a bit more why Indonesian patients are different, then we could understand where to focus the research. But I don't know whether there's a National Research Council which, decides on priorities for health technology assessment. This is one of the questions we hope in our mapping to begin to pin down who's actually involved in this, because the primary research is one of the problems, and I found this when we talked to doctors in the UK about actually good clinical practice. The number of them who would completely ignore what was already known, which is a bit depressing, because they said, oh, we need more research, we haven't got the evidence on this. But there are a lot of things we had plenty of evidence on, like prescribing antibiotics in myocardial infarction. We don't need a lot of evidence on that. So why aren't we implementing it? Anyway, sorry, I don't know the answer. I think somebody ought to get a nice fat research grant and spend a little bit of time doing it. Further observations, questions? I did ask the students, do you think you're being taught the right things for tomorrow's doctoring? You're postgraduates, you've all been through that. If you look back, what would you have liked to have known more about? Nothing. Well, if you're not going to say anything, maybe I should talk to you about external assessment. We were due to finish at 12.
Baik Bapak Ibu, kalau tidak ada pertanyaan, Dr. Charles menawarkan apakah akan disampaikan mengenai external assessment, jadi penilaian sarana pelayanan kesehatan dari pihak eksternal, misalnya untuk perizinan atau untuk akreditasi. Apakah berminat atau kita cukupkan? Ya. Bagaimana? Yes, we can continue. How long it will be take? No.
Given I thought we meant to finish at 12, so I'll just very briefly mention external assessment. I haven't got the slides here, so I'll just have to talk you through. I mentioned earlier that I use the word external assessment to include certification, which is like ISO assessment, usually against ISO 9001 standard, which was designed for manufacturing industries. It was not designed for healthcare. And quite frankly, it's very difficult to apply in healthcare because nobody knows quite what it means. So people who have an ISO 9000 certificate, particularly hospitals, it's great to put it in the front hall and impress the customers, the patients. It isn't terribly good at saying you're a good hospital. And I'm prepared to argue that with anybody. I've had this argument in Europe a lot. So ISO 9000 is better than nothing because it makes you work towards systematic, documenting what you do and measuring what you do and proving what you do. So it is better than nothing. In the European Duke study, it actually seems to be almost as good as accreditation in terms of what we can identify is the impact on the organization, which makes me think that we did the wrong test. We didn't measure it right, but that's our fault as researchers. So their certification is one, and that, of course, is available in every country, and it's probably cheaper than accreditation. But does it work? You've then got regulation, and in Indonesia, I'm still trying to work out the relationship between licensing of institutions and hospitals and CARS accreditation. I mean, should the new health insurance be limited to people who have been relicensed? And as far as I can gather, you get a license once and then it's forever. This happens a lot in Europe too, that you're required to have a license to operate a pharmacy, you're required to have a license for medical devices, equipment, you've got to have a license to operate as a public institution, you have a license to operate as a hospital. But nearly all of them, you simply pay for this when you open the hospital, or before, when it's constructed. And then nobody goes back again. I was sitting with the manager, or director of a general hospital in Sarajevo, in Bosnia. And he said, "Oh, you'll be pleased to hear I've got my new license." I said, "Oh, that's good, that's good." He said, "Yes, here it is. It's arrived this morning. I said, well, I didn't know that they'd been in to inspect you. Oh, no, I just pay. And I think a lot of licensing systems are like this. So I don't know what happens in Indonesia. What's more, one of the problems of licensing is it often is decentralized, such that it's no longer the national government or ministry, it's the provincial ones or even municipal ones. And the same thing's happened in India, where the state governments have devolved it down to district level. So now you've no idea whether licensing in one district is anything like licensing in the next district. So there are always problems with decentralizing health services. And we have this in Europe right now because there's so much devolution of registration and licensing. We really cannot keep track of performance across borders. And in Italy, it's the regional governments who have all the power and the money. So the national government cannot coordinate within Italy. So when the European debate is about patients moving across national borders, in Italy, there are 23 national borders within Italy. So, and I think we're going to have the same problem here, I suspect. But certainly part of, again, this mapping exercise is to try to see who actually is inspecting what against what standards. So then we come to cars. And we're still trying to clarify this, exactly how many hospitals are accredited or when they were accredited and what's the process by which they're accredited. We would like to think that if JCI come to survey an institution, their report would look pretty similar to if CARS surveyed an institution, especially given that the new CARS standards are largely JCI standards. They made some adaptations, and I think that might make me question a little bit the validity, so whether they've been tested or not in the new setting. There's also questions about how often do you need to repeat the assessment. Every year? Seems too much. I mean, it's manpower heavy business. It's quite disruptive to hospitals. So how can you get the benefits of a thorough, deep, clean look at you and the economy of time and so forth? Also, for how long should you be accredited? Worldwide, the answer is no more than 3 years. Why? Because if you give people a 4, 5, 6 year permit, they say, that's tremendous, now we can relax and just get on with life. And everything goes down. The French, paradoxically, have gone up to 4 years. Why? Because they can't manage the workload in their 3,250 hospitals. So it's simply a matter of balancing the resources that they have against the workload to be done. So the detail, actually how much work is involved in a survey. So I had an interesting chat about this yesterday. To what extent is it a matter of simply verifying line by line compliance with a standard? Or is it an intellectual management analysis of themes that run across about leadership, themes about staff attitude, culture, and you can't pin that down on any one criterion. So is your accreditation report going to be a sort of a psychotherapist's analysis of this institution rather than just a line-by-line compliance? If you want that, it takes a lot more time and effort. So what is it you want? So I think to define why we do accreditation, what are we doing it for, would help to define how much effort we need to put into it. There's also a lot of discussion around the world about whether you should ever plan a survey or whether you should ever tell a hospital that you're coming to assess them. I know I've been on the receiving end as a medical director in Bermuda. I know how much time we devoted to working through the standard self-assessment committees, working parties, and how much time we diverted from looking after patients. Even though we were already, let's say, 92% ready, we were working very hard to get to 93%. And there's an interesting thought, particularly among the school inspectors in the UK, saying, look, we don't want the staff wasting their time getting from 92% 93%. We would say every institution should be ready for the accreditation people at, let's say, a week's notice. Somebody has to plan operating lists and so forth. So, you cannot come in completely unannounced. Well, you can, some people do, but not for a complete survey. But essentially, you should have all your procedures lined up. You should be able to have the minutes of your meetings, your infection control minutes. You've got this done, you've got that done. It's normal. It isn't something you just do for when the accreditors come. So one way of going about this is say, we're not going to tell you when we're visiting. We'll tell you it'll be sometime in 2014, and we'll give you 7 days' notice. So be prepared. It might be far less disruptive to hospitals to do it that. What else should I say? What's the link between being accredited and insurance companies, insurance payments? I met with some of the people who are planning your universal health coverage last week, and I think we agreed that the insurers need some third-party assessment of healthcare providers to give them a clue, is this a competent organisation that we should be dealing with at all? If so, we will be prepared to talk contracts specifically for services like acute myocardial infarction. But the question is, who is a good, reliable third-party assessor? To what extent does accreditation, whether it's by CARS or JCI, actually tell the insurers, this is a good organisation to deal with, we'll be willing to talk. So, quite honestly, I'm a bit surprised that so little progress has been made on actually even proposing the associations between insurance and accreditation. And in Australia, when it was introduced by the ACHS, the Australian Council of Healthcare Standards, there was a $10 a day inpatient premium for accredited hospitals. $10 may not sound a lot, but when you multiply that by several thousand patients in a year, that's quite a lot of money. In Estonia, we're talking about maybe a 1% difference, so that an accredited hospital, or at least an approved hospital, we don't have accreditation, next year's cost of living increase, suppose the average cost of living was allowed at 2%, that the accredited hospitals would actually get 3%, non-accredited would get 1%. So you're not actually talking about putting new money in the system, you're just talking about moving the same money to favour the accredited institution. So, frankly, we haven't got to that, as far as I know. And I really find it hard to predict what's going to happen in January 2014. It's past time. I think it's time I shut up now. So if you've got any other questions on external assessment, do let me know.
Ada pertanyaan? It is very interested about the quality system integrated. Let me show the slide. Integrating quality system. We are come from the different healthcare institution, several from hospital, several from health office, several from education institution. Right now we do not know what our role to develop this integrating quality system. Menurut pendapat Anda, apakah Anda mengetahui peran Anda dalam membangun sistem mutu yang terintegrasi ini? Sudah tahu lokasi Anda di mana? Ya. Kalau orang-orang rumah sakit ada di mana? Manajer rumah sakit. Leadership management. Oke. Kalau dinas kesehatan? Dinas kesehatan? Kalau klinisi kan ada yang dari PPDS, klinisi. Pathway. I asked them about their role in this to develop the integrating quality system. If we are as a hospital manager, they say that the role is for develop the leadership management. If they are the province or district health office, the role is somewhere between Ministry of Health for planning in local. If they are a resident for specialist doctor, the role is for develop the clinical pathway. If they are institution for academic institution, the role is for training. How do you think about to develop the national integrating quality system with the framework for involving all of stakeholders in hospital? Where we starting, and if we have 1 January 2014 as a starting day for the universal coverage, it is the best time. I don't know.
It's like having a baby. There's never a best time. Or for students, I say, starting a PhD is never a convenient time. You never suddenly have 3 years with nothing to do. Coming back to this, though, the point you raise is exactly the rationale for trying to develop an agreeable national proposal for how quality could fit together in a given country. Because this discussion takes place in many countries. What I think is important, and this is where the mapping exercise comes in, is trying to identify who are these people, what sort of measurements are they developing, what sort of standards are there out there, and we'll try to put this into a framework, a proposal, which could be examined by a number of stakeholders, and clearly you are some of the stakeholders, in order to get a general agreement about the common elements, about science, about involving the public, about transparency, about value for money. If we could get everybody to agree on the same basis, we've got a great deal more opportunity of making sense of it. But then, partly the question is, how do you ask people this? In some countries, we would take this to the Ministry of Health, who would say, thank you very much for doing this research and this work. We will now formally distribute it to all of the stakeholder representatives, the professional associations, the colleges, the healthcare insurers, the health authorities, the regulators, and we will ask them over a period of 3 months to respond to us, and we will collect all the responses, we will publish all the responses, and then we will draft a national policy. But that doesn't happen here, as far as I know, and I'm trying to find a way around it. I did last March talk to the CARS commissioners about what I think is going to have to be their new governing body, a governing body that would represent many of these people. It would represent the hospital managers, represent the academics, the teachers, represent the professions, and the public, and the health insurers, and the ministry. So it's not driven entirely by the ministry, it's not monopolized by any of these groups. Because that's the sort of body to which you could pass a draft policy and ask them to distribute it to all their members. We haven't made much progress with that yet. So I think this is part of the problem of implementing change. Who do you talk to? How do you talk to them? There's one country where I thought we got a success with something like this, because one day I flew in from London and they greeted me and said, "Oh, it's good, the minister has signed the policy." I said, I didn't want him to sign the policy. I wanted him to talk to people about it. I wanted him to talk to the professions, the doctors, the managers, the insurers, to get them to understand it and agree with it. So it's a matter of, do you want in Indonesia to move from a top-down, waiting to be told what to do, or do you want to set up a system whereby you share ideas, you share knowledge, you regulate yourselves, and you make proposals and pass them upwards? Am I treading on difficult territory here? Because this is very much culture related. And as I was saying a little bit earlier, that in post-communist states, there's still a great fear of anybody taking initiative. You just wait to be told what to do, and then you pass the instruction to somebody below you. It happens in India a lot. And trying to get people to think positively, take a lead, take the initiative, and tell the ministry what they should be doing. It's difficult to change the balance, but it's the same thing with professions about clinical audit and self-governance. You know, somebody has to start this movement. We're on the way, but I'm not quite clear what the next step is. So I can't answer your question.
Baik, Bapak Ibu, karena waktu sudah siang, kita cukupkan guest lecture ini. PR kita banyak sebenarnya untuk para mahasiswa S2. Ini bisa menjadi salah satu topik tesis. Ya, jangan semuanya, satu aspek saja cukup. Ya. Bagi para praktisi, ini juga bisa menjadi kerangka pikir bagaimana meskipun kita sekarang sudah mengatakan BPJS akan menjamin akses dan mutu. Ya, kalau akses mungkin ya dari sisi pembiayaan, tetapi mutu bagaimana? Nah, ini bisa menjadi salah satu kerangka yang bisa kita pikirkan bersama. Baik, kita berikan aplaus kepada Dr. Charles Saul. Thank you very much for your guest lecture. Kita bisa bertemu kapan-kapan. Ada di website, bisa di-download baik videonya maupun PowerPoint-nya. Yeah. We have your video tape in our website and PowerPoint as well as PowerPoint. Thank you very much.